So on the service, we have been able to position ourselves to be not just participants but also leaders in clinical trial work. From looking at Fuchs dystrophy and understanding how this disease progresses in terms of natural history, that's one effort that Dr. Matharu and myself have been involved in a study called the DTX trial, where we're looking at the natural history of how this disease progresses. Big picture, Fuchs dystrophy, the number one indication for requiring cornea transplantation, there is a lot of work that's being undertaken to understand the progression of this disease. We're trying to understand where it is that medical therapy might be able to fit in to treating this disease. Currently, only surgical options are available. In the very near future, 5 to 10 years, I would predict there are going to be not one, but probably multiple medical therapies that might become available to help prevent the progression of Fuchs dystrophy from requiring surgery altogether. That's the future. And we're absolutely leading on that. This DTX trial, natural history, we're participants in it. The work in my lab on the actual basic science and translational science side of things, taking it from the bench to the bedside, we're leading in that. So in my lab, we've got a variety of funded studies that have been really exciting. Initially, we had an R21 that has been investigating Rho-associated kinase inhibitors. So you think glaucoma and the drops that are used to lower eye pressure, like Repressa and Notarazidil. There's another version of a Rho kinase inhibitor called Rapazidil, which is being used in non-transplant treatments for Fuchs dystrophy, decimate stripping only. You just take out the diseased part, and instead of just letting nature take its course of trying to heal a wound on your endothelium, and that takes a long time because these cells don't divide, if at all. In some of my colleagues abroad are using Rho kinase inhibitors, Rapazidil in particular, to try and speed the closure of the endothelium. The Wild West is kind of where we're at with these drugs, in my opinion, because we don't have any standard algorithms. The pharmacokinetics aren't exactly worked out. We don't know the dosing. We do know that Rho kinase inhibitors cause red eyes, blepharitis, treatment intolerance, pain. And so we put together this grant application and got funded a couple of years ago to do a head-to-head comparison between Rapazidil and Notarazidil as a treatment potentially for improving decimate stripping only, trying to understand, all right, what's the best dose, which is the most effective medication. And also part of this study was trying to understand whether, without taking out diseased parts of the cornea in Fuchs patients, can we use these medications to actually stabilize the cornea and prevent the progression of that disease. So the NIH took an interest in us. That was our first grant in cornea, not just our lab, but the first homegrown federally funded grant at the University of Iowa ever. That helped us plant a flag, down in the world of nerds. And the NIH recognizing our lab and our efforts in Fuchs dystrophy, I think that was a great background for putting in our grant application for the most recent grant that we got, and that's to understand whether or not this disease mechanism that's driving the progression of disease, called ferroptosis, is something that we can modulate and exploit the known points in the mechanism to understand if this particular drug of interest that we've been developing as well, not Rho-associated kinase inhibitors, but ubiquinol. That's the business end of coenzyme Q10. And we know from studying and mapping out the mechanism that ubiquinol does have a very potent footprint in thwarting the progression of Fuchs dystrophy in our models. And so when we put together our package for this application from NIH, they said, yes, you've got great science, here you go. And so we got the go ahead, and now this is the second grant that our Cornea service has been able to really put out there in Fuchs dystrophy and in pharmacoprevention and drug therapy for creating a scenario where we can make the management and treatment of Fuchs dystrophy non-surgical, medical. The way I would sort of imagine seeing the natural conclusion of what we're going to be doing with both of those grants is putting forward drugs that are effective, and the preclinical work that we're doing here as part of these grants lead us to the next phase that's going to happen in the next few years, where we come out of these grants with molecules that we know in the preclinical space work. Now we need to actually get these things manufactured and put into the pipeline for phased human clinical trials on the way toward FDA approval. That set of efforts is going to take a number of years, and we're leading that effort in a big way. It's been very exciting. We're getting a lot of positive feedback and putting out some really good grant work. So and papers that are in development right now. This whole package of Fuchs dystrophy research doesn't just stop there. Chris Salas just came out with a wonderful paper that he led on Fuchs dystrophy and the functional impact of having Fuchs. We talk about how to stop its progression, and that's important, but we also need to understand what its effects are and why to prevent that progression as early as we can. He put together a functional assessment at the National Driving Simulator that Mark Wilkinson, our fantastic optometrist, has been associated with the NADS for a number of years. Dr. Salas had this driving simulator put patients with Fuchs, comparing them to age-matched patients that didn't have Fuchs, both sets of populations having had cataract surgery, so we could understand what's the functional impact of this disease on our patients. And he came out a great set of findings that showed driving impairment is a very real thing. Even people who are 20/20 on the road, they're not necessarily feeling safe. That's what they're reporting to us. And he objectively was able to demonstrate, if we look at these patients and their pentacam images, which we get frequently in clinic, we can correlate their symptoms with an objective metric. And now all of a sudden you have a more real dimension for these pharmacotherapeutics that we're trying to develop. Can we get to them early enough, these patients, when they're not having symptoms, before they have these kinds of impairments? So we have functional metrics that are being built alongside the molecular treatments that we're trying to develop, so that our impact can actually make a real world difference for these patients.
Yeah.
And then to help round out some of the Fuchs stuff, my group is also looking at the images that we take clinically. We get these microscopic images of the cells, the corneal endothelial cells that we're trying to protect. And in Fuchs dystrophy, you have this accumulation of these spots, these disease spots, where the cells have gone away and died off and have been replaced by these these mounds of diseased collagen called guttae. In the way that I explain it to colleagues and some patients, especially ones that have retina understanding, this is the cornea equivalent of drusen in the back of the eye for macular degeneration. You get this accumulation of stuff that kills off the cells around it. So we've been looking at software to help understand how quickly those guttae, those disease spots, accumulate. Not just looking at the cells that we're trying to treat and stabilize, but also looking at the accumulation of literal, garbage material that those cells are secreting, because that's part of the disease process. So we've developed a software that we're in the process of licensing to the leading manufacturers of these specular microscopes that give us these images, so that we can build this tool and make it available to investigators in the clinical world, ultimately, certainly in the research world, as soon as possible, so that we can track the progression more with a higher fidelity and more attention paid to the actual cells themselves that we're trying to stabilize. Big picture, in a number of years, these kinds of efforts, functional real world, in the clinic, diagnostics, those are going to be needed to bring these drugs forward and get FDA approval and have a reception in the real world. So there's a lot going on with our Fuchs research. In addition to all of that, the clinical trials that we have going on in the world of cornea, we've got one that's wrapping up and one that's ramping up. The one that's wrapping up is the diabetes endothelial keratoplasty study. Diabetes has been a big research focus in my lab for over a decade, and it started with the sentinel finding of Greg Schmidt at the Iowa Lions Eye Bank. Our research director, when he was the director of tissue processing, had a sentinel event of observing that the DMEC graft tissue that we prepare tears more frequently if you have diabetes. We described that. We got some good impact with that. Impact to the point where, after chasing down in my lab systematically why that was, confirming that that was a thing, understanding what the impact was to the endothelium and the backside of the cornea, all of those papers made a big impact and led to the funding of a prospective randomized multi-center clinical controlled trial called the Diabetes Endothelial Keratoplasty Study, or DEX. DEX is just getting to the point where we're going to report the initial data. So there are going to be two papers hopefully coming out here right at the time of the next AAO meeting that are going to describe what those findings are. I know the data. I can't share the data. This is all one, big discovery that, we're going to see as we put these data out in the world. And we are pretty confident that they're going to have an impact on a major, national level, if not international level, because this study is trying to understand the impact of diabetes on donor tissue and outcomes of DMEC surgery related to that impact. We're looking at graft success. We're looking at cell survival and how the cells change over time. So that's really exciting. Our pole position with that initial sentinel finding all the way through all those papers, that got me a seat, and also Greg Schmidt seats on the executive committees, for this trial. So that's super cool. That's all concluded in terms of the patients that we've been able to recruit and treat as far as that goes. And the service now, Ken Goins and Kamal Matharo and myself are going to be investigators on this next trial that we know is also going to have major impact, and that's called the Parasitic Ulcer Treatment Trial, or the PUT. So the PUT study is another one of these multi-center randomized clinical controlled trials, not attendant to the corneal endothelium like a lot of my other work is. In this case, we're trying to make a dent in the man versus microbe fight that defines humanity. The microbe that we're studying is acanthamoeba. Acanthamoeba, one of these really resistant parasitic infections that can cause blinding infections, very painful ones in patients. They're contact lens associated infections. They happen rarely, but as some of our work a number of years ago described, there was actually an outbreak here that got reported in the CDC that we were sentinel in describing. And that paper and the understanding that acanthamoeba happens in places like Iowa because this is a moist river valley, Mississippi River Valley, sort of location. These parasitic infections are waterborne and soil-borne, and they happen here with a frequency that along with our demonstrated interest in studying this, got us a seat at the table for participating in this trial. So I'm helping to lead that. And what we're trying to understand in that study is the impact of steroids on outcomes. When a patient has acanthamoeba, some patients are treated for something else. It turns out they actually have this, and by the time they come to us, they're already on steroid drugs, topical medications, and that in the literature is a big risk factor for delaying diagnosis for this infection. However, steroids make sense because infections cause inflammation, and the inflammation can be destructive. So there can also be an opportunity for a therapeutic benefit for steroid medications, eye drops. And so there's an open question. Do steroids, topical steroids, make a positive impact after you start treatment for acanthamoeba? You know you have this infection, you're treating it definitively for a month. Now, at that point, we're going to be randomizing patients to receive placebo or topical steroids to understand the impact. And that's an ongoing thing. We're just about to start enrollment on that. That's going to be a good few years of enrollment as well. And I think the reason why we're doing all this work, and that's not even all of it, that's just, it's a good bit of it. But the reason why we're doing all this work is because these are real world problems in ophthalmology, not just in Iowa, not just in the United States, but abroad. And we are sitting in a position where we're able to participate and able to lead and able to carry forward not just clinical acumen and investigations, but also translational ones where we're not just able to assess this intervention versus another, but bring that intervention to the possibility that this is a treatment for everyone. So it's going to be a really exciting number of years that we've got ahead just doing the work that we've got. Where are we going to be 5 years from now? I think that we'll be further toward the goal of getting medical therapies for Fuchs dystrophy off the ground. I think we're going to be able to understand whether or not we can treat infection better. We're able to understand better whether or not we have to be sensitive or not sensitive to the impact of diabetes when we're dealing with our transplant issue. Transplant supply is a big issue. Donor shortage is real, not necessarily here in the United States right at this moment, but worldwide, there's only one cornea available for every 70 that are needed. So understanding how much we can push on making that commodity, that precious resource available for patients in need, and making sure that patients who really need it can get it. That is a major motif of a lot of the surgery that we're doing, or a lot of the research that we're doing. So it's exciting. We're going to have a lot more information.